Good afternoon, everybody. Many, many thanks to Joe Chiani, to Michael O'Reilly, to Paul Jansen for the invitation and the help to be here today. This is a fabulous thing to be talking about. It is so incredibly important because there are very, very few times in your life you can actually point to something and say, this exactly saves lives. And yet, what we're talking about today saves lives. So I'm here twice on the dark side, right? First as a surgeon and then as a venture capitalist. How they managed to make that mistake and let me here, I'm just not sure. But I'd like to talk about, let's see, am I doing the right thing? There we go. I'd like to talk about a perspective which may be a little bit different than you hear from other people. I'd like to talk about a surgeon's perspective which talks about technology in patient care, technology in surgical technique and technology in patient safety and quality. And we're talking here about the value. We're talking about data, we're talking about monitoring, we're talking about technique, we're talking about improving what we see and ultimately about improving what we know so we can improve what we do. From a venture capitalist perspective, I'm going to be speaking about something a little bit different. Venture capitalists are interested in technology, they're interested in innovation, and their responsibility is to take money that they receive from limited partners who want to invest in these areas and provide a return. Those of us who work in the healthcare arena are working on more than just a financial return. We also want to denominate our return in benefits to patients and benefits to the system. So we have three things we need to talk about. First, a return on investment. And that is a matter of the size of the market. It's a matter of the risks that we're talking about, how long it takes, how much money it takes, what the regulatory problems are. We talk about how to differentiate product. What are the characteristics? What is it used for? When pulse oximetry first came up, the people like Joe who were visionaries said, you know, we're going to use this on every patient. And people said, why? Why do you need to? Well, we're hearing now why we need to and why that vision was correct. But we're also talking about something else really important, which is how you drive adoption. If you don't have adoption, you don't have a product, you don't have a market, and you don't have the benefit that you're trying to achieve that then pays back. So this is really trying to do well by doing good. Venture capital is interested in adoption. Without adoption of technology, you're not going to have investment in technology. Without investment in technology, there won't be any new technology. Without new technology, you will have only limited advancements in medicine. This summit is very special because it unabashedly talks about making a difference in driving adoption. If there's anything you come out of this with, it's adoption matters. And let me tell you a little bit about the story and how that happened. New technologies have been important because they've had an impact on medical advancement. Sure, we all know that. We also understand the benefit to patients and to clinicians. What we often don't understand is that the system itself is benefited from the advances of technology because they give us knowledge. But there's a problem. There's always a resistance to change. And de Montaigne said, nothing is so firmly believed as that at which we least know. And as probably all of you know, 98% of all physicians are in the top 10%. So resistance to technology is old hat. 1895, blood pressure was introduced, and the sphygmomanometer, the blood pressure machine, would not be welcomed by the overworked and underpaid general practitioner already loaded with thermometers, stethoscope, and so forth. But the story is actually really interesting because it goes further back and further forward. And there's something that I like to call the parable of sterility. We all know about sterility and infection. We all know about Pasteur finding microbes. But what we may not know is how completely he was disbelieved for many, many years. And so Lister, a surgeon in Scotland, saw that garbage was being disinfected with phenol and thought that might be helpful for patients. Put it on compound fractures, and in 1867, after working on this for about 15 years, was able to show that if you disinfect a wound, it won't get infected, and an open fracture didn't have to be amputated. And so he published this, bitterly contested, too narcissistic, who needs it? There was a public demonstration by Sir Victor Horsley, a very famous surgeon and neurosurgeon, in 1886. 2 hours, 15 minutes. 2 weeks later, the London Medical Journal said, Mr. Horsley performed an admirable operation, but had he been a better operator, he would not have needed sterile technique. As important as a figure as Halsted at Hopkins was concerned that sterility made surgery too easy, and surgeons were going to lose their edge. For many years, many years, surgeons worried only about technique. In 1912, the Nobel Prize in Surgery, or Medicine, was given to Alexis Carrel, who turned out to be a brilliant scientist, but what he initially did was get a Nobel Prize for figuring out how to sew two vessels together. That was the level that was needed. Over a number of years, additional techniques came. First of all, diagnosis. Do you operate in order to figure out what's going on or to fix what's going on? Technical improvements in safety. How do you make needles? How do you make sutures so they don't break? Localization and imaging. You know, the CT scan was actually not a way of imaging. It was a way of finding more operations. And that's why it was adopted so quickly. And then minimally invasive technique that made a huge amount of difference. So there were important shifts. The first shifts occurred when maybe 20, 25 years ago, surgeons started saying, let's see, surgical process, should that be inpatient or should that be outpatient? How do we do it better? We're making surgery better. Then we talked about efficiency and outcomes, centers of excellence, case morbidity as opposed to operative morbidity. Those of you who know the field will know that about 30 years ago, we started operating on aneurysms much earlier than we did before. More patients survived, even though the operative results looked worse for the surgeon. But on the whole, from a population perspective, it was better. And then effectiveness. Do we look at populations, like all patients with aneurysms and subarachnoid hemorrhages, or do we look at individual patients? So the first part is to make surgery better. The next thing is to make outcomes better. And the last part is when we start talking about making patients better. Our current focus in surgery is the WHO idea of patient safety. That's what we're looking at, identifying and measuring harm, understanding causes, solutions, impacts, and then translating that evidence into clinical protocols. What's wrong with that? What's wrong with that is that it's not taking action. In order to take action, you need to find the performance gaps. We need to find not just technologies, but existing technologies that can make a difference, existing technologies that can be applied. Not just ideas for change, but actual recipes. Actual recipes, I think, are like learning how to sail. Somebody doesn't say, take the sail, hold it in your hand, and find the wind. They tell you what to do, because it's not enough to just be told inspirationally, go find the wind. We need to get the leadership of hospitals involved. But here's the thing. There's a reciprocal relationship between leadership and leaders. So people who take leadership positions in doing things like that are the next generation of leaders. We need implementation strategies. It's not enough to just say, go do this. Who checks up on it? Who is there to encourage people in the middle of the night when it's late? Who's there when it seems overwhelming? Who's there when something fails? And things do fail. And then what we often forget is the importance of continuing support and education. I think I took my driver's license test a long time ago. We heard about that from one of the earlier panels. I don't know whether I can actually pass the driving test today in terms of all the rules. I drive pretty well. You constantly need reminders of what actually matters. Well, in this summit, we're going to be privileged to hear about the three really important areas. The failure to rescue post-op, the respiratory depression. Let me speak as a neurosurgeon for a second. This has nothing to do with respiration only. This has to do with when I call Mike O'Reilly in the middle of the night and I say to him, I think my patient isn't doing well, and I think respiration is one part of it. It's a sentinel sign. It's not just the fact that at one moment the respiratory rate has changed or there's just a trend. I worry because it's one of the most single sensitive signs of what's going on in the brain or what's going on in the spinal cord. And I've got to know that. I have no better sign overall of what's going on. That's why this matters. And the solutions matter because the solutions give me data. And the more data we have, the earlier we can figure out what's wrong, whether to take a patient back to the operating room, whether to reverse narcotic, whether to do something else that I haven't heard of yet. That's why this matters. The reason that the medication errors matter, well, personal, between 1 in 10 and 1 in 20 patients who have a medication error will die. The numbers are huge, 1 million, 1,500,000, maybe 2 million a year. My father was one of the ones who died with a medication error, even though he was surrounded by his family, who seemed to have medicine as a family business. But it happened anyway. And the answer was, when we inquired, well, it couldn't be helped. Not true. Wrong attitude. Not only can it be helped, it has to be helped. And the more medications, don't think of this only as one medication error. Don't think of this as one administrator, one infusion pump, one particular IV. Most patients that we see today, especially as patients get older, are on multiple medication. And just as much as you can have an error in one medication, you can have an error in multiple medications. The vulnerability is huge. And the technology is there not just to save a patient from one medication error, but from the risk of multiple medication errors. Transfusion overuse is one of the few places where you can actually show you save money. You actually do very, very well economically by doing the right thing medically. It's a similar message. Formalize, check, recheck, measure, learn. The formalization is what we need to learn from these three areas. Are they the only ones? No, but we have technologies to deal with these. And that's why they matter so much. Technologies are not all interchangeable. One of the things that I think you will hear, maybe some of you with some surprise at this summit, as we will be talking about specific technologies for specific applications. All technologies are not alike, just as all drugs are not alike. And just as many of you who've dealt with medications know the importance of sometimes choosing a generic and sometimes choosing a branded drug, the same thing holds true when we're dealing with technologies. And it's without any shame that we say look for technologies where the brand, the actual name of the technology, has been shown to be associated with the results that you want. Specify and name. Don't just talk about a technology and expect that that technology is going to be done well. The next thing is to think in terms of recipes. Again, this is not a question of generally what to do. Not a question of just saying, well, let's monitor respiration. How do you monitor respiration? How often? Who looks at it? The idea that we have technologies that will not only monitor, but also communicate to the staff is critically important, because it's very easy to get tired, it's very easy to ignore, it's very easy to get confused, and you want to know exactly when something changes. This is about trend analysis, whether you're dealing with medication errors and there's a change, whether you're dealing with respiratory failure and there's a failure to rescue, whether you're dealing with transfusion, you want to know in real time what's going on. And the recipes say when X, Y, or Z happens, this is the way you respond. Several people here are pilots. I was a flight surgeon. The checklist mattered, but the other thing that mattered in addition to the checklist was making sure that people actually followed the checklist. It's really important, and we forget that. And we also need to select for people who are going to follow the checklist. So one of the things that we need to talk about is not only simulation for individuals, but simulation for teams. We need to select for people who are going to be empathic and who care about these kinds of problems. Those who want to work in a team to better the way in which we practice medicine. And we have to provide continuing training for teams together. The last thing that I want to talk about is the idea of rights of patients, rights of institutions, rights of clinicians. Patients have a right to their own information to know what's going on with themselves and to good data. Clinicians have a right to patient data when they need it and where they need it. Hospitals have the right to data that is good data, to use those data to do things better. If they don't know, they can't see it. And that's the responsibility of the companies that many of us are associated with, to have those data, to secure them, and to share them openly. Now, it turns out that rights are only part of the equation. Wherever there's a right, there's a corresponding obligation. And what I see as a surgeon, and what I also see as a venture capitalist and innovator, is that we have an obligation to make sure that these rights are actually respected. At the end of the day, all of us who are involved with medicine and with patient care, all of us who are involved with biomedical engineering, care about what we're doing because we think it matters. And the great thing about this is what matters, matters. I think we've gotten to a point that this summit emphasizes that what happens to the patient can actually be improved by the judicious application of certain technologies, and that the knowledge that comes from those technologies needs to be shared, disseminated, and above all, acted upon. Thank you very much for your attention. I think this is going to be a fabulous conference, and thank you very much for inspiring it.